minimize the screen, but I guess I can. Let me see, I'll play it from here. Okay, so here we go. Well, Carla, thank you so much for having me. Today I'm gonna pretty much talk about the team approach to airway management. So I think it's great that you have so many people attending this. I'm honored and humbled. A little bit about me. I am a restorative dentist. I do not have a typical sleep practice. I never started that way. So my bread and butter was restorative dentistry. So I'm accredited with the American Academy of Cosmetic Dentistry. My background in restorative is pretty much trained at the Coy Center. So what I love about the center is we really focus on risk assessment. And recently, I connected with Jeff Rouse, and I come to the Spear Center to help mentor the Airway Workshop. So these two guys have been such great mentors and important people in my life. This is my local sleep and airway group. What happened was when I had an epiphany about the management of sleep disordered breathing, I realized that the dental community had a stronger impact in managing this disease, but yet we're not invited to the table. So I took it upon myself to develop an entire group. And what I did was I asked all of my referrals, basically, you know, I'm one of those docs that I have two doctors per specialty. And, you know, usually if I ask them to do something, they're going to say, okay, because, you know, you don't want to bite off the hand that feeds you. So we all met, and I told them my vision. I said, look, guys, I think we have an important role, and I need you to help me. So this was our group. We meet every month, and we kind of discuss cases. I show reports and reviews. So it's really nice. We have an ENT, sleep physicians, and every discipline in dentistry, and myofunctional therapists in our group. My latest venture is ASAP, and this is Michelle Weddle, Stacy Ochoa, and Jameson Spencer. Basically what we decided to do, and Jameson Spencer has a big sleep, adult sleep online education program. So we decided to have a pediatric one. So that it's basically like a sister program of the Spencer Study Club. The interesting thing is, while it is pediatrics, you have the adolescents that are kind of not growing. So we do touch upon the non-growing children. So let's kind of review the traditional medical model. So the traditional medical model starts with a sleep physician, an ENT, and a medical device provider. So the sleep physician is going to render a diagnosis of obstructive sleep apnea, and they're going to do that either with an in-lab sleep test or a home sleep test. Then ENT is going to remove the soft tissue, and the first thing they're going to do with kids is they're going to take out the tonsils and adenoids. In the adults, they're going to do what we call a UPPP. That's a uvular-pharyngeal palatoplasty. That's where you cut the soft palate. And then if that doesn't work, they're going to do a tongue-based reduction, because the two common sites of obstruction is going to be the soft palate and the tongue. So that's kind of how they're going to attack it. The medical device providers are going to give you a CPAP. That's a standard of care for adults and is also a viable treatment for children that are symptomatic post tonsils and adenoids. What we're most familiar with is oral appliance therapy. And the latest kit on the block right now is Inspire. Inspire is a device that's implanted in the body that signals to the tongue to push the tongue out of the way. There are actually a couple oral surgeons that are doing this in their office too. The problem with this traditional medical model is it's very limited to the screening. And like we talked earlier, it's pretty much you're dependent on your primary care and your pediatricians to do the referrals. Another thing with this model is it's really just focused on damage control. It's really focused on how severe are you? Do you have obstructive sleep apnea? And how many events do you have? So let's look at this model and see how well it worked for him. This is Rob. Rob is 67 years old. And when Rob was 37, he was diagnosed with obstructive sleep apnea. When Rob was 37, the sleep physician gave him a CPAP. And so he gave him a CPAP and he said, I still feel like crap. So then the ENT got involved and said, you know what? The number one side of obstruction is the soft palate. So you know what I'm going to do is I'm going to cut the soft palate. And that's what he did. At 37, he got a CPAP, didn't like it, couldn't wear it, cut the soft palate, still did not work. If Rob went to the dentist, we would have really kind of take a deeper look at this. We would have been like, yes, that soft palate is obstructive, but what is obstructing the soft palate is the tongue. That's why when you cut the soft palate, it still doesn't work because that tongue still doesn't fit. Why is this tongue obstructive? Well, the tongue doesn't fit in the dental arches. What houses the dental arches is the jaws. So if you kind of look at him, he's both bimax retrognathic. And if you go and you look at his nose, he can't breathe. So maybe if we had a dental consultant in the early end of this treatment, we wouldn't have need to cut his soft palate. So I don't really think this medical model did a great job for him because now he's 67, still with severe obstructive sleep apnea. And now his treatment is pretty much going to be double jaw advancement. Let's look at how this model worked for Riley. So this family of 3 kids, all 3 kids have some form of sleep disorder breathing. But we're going to talk about Riley. At the age of 3, Riley was diagnosed with obstructive sleep apnea and they took the tonsils and adenoids out. At the age of 4, Riley was still very symptomatic and they put her on the CPAP. Riley had the same problem as Rob. Riley's soft palate was obstructing her airway. But unlike Rob, you're not going to cut the soft palate on a 3-year-old. So the ENT was like, what are we going to do? So they did a procedure called DICE, when it's drug-induced sleep endoscopy. And what that is you put a scope through the nose into the airway and you want to see what's going on. And the ENT confirmed that, yes, everything actually collapses. It's a soft palate pressing up against the tongue. I bring the lower jaw forward. Everything is collapsing. So we get the referral to the dental office. So if we look at her face, we can see that she's mid-face retrognathic. So the treatment was we are going to expand her and bring her jaws forward. And within a year, we were able to eliminate CPAP therapy. What the ENT and the sleep physician didn't realize is that while the soft palate is obstructive, that soft palate is connected to the maxilla. And the best person to address the maxilla is the dentist. So while they put her on a CPAP to make her better, they were making her craniofacial risk factors worse. So let's look at the dental treatment. Typical dental treatment is an oral appliance that manages the mandible, and we have double jaw advancement, and we know this works. The younger you are, the higher the success rate is. The older you are, the more comorbidities you have. So obviously the success rates go down a little bit. But what both of these treatments don't do is it really doesn't dive into the why. Like, let's go backwards. Let's go back in time and let's kind of figure out, how did we get here? Could we have prevented Rob from getting all of that treatment? Could we have done something to Riley before her face went back? So when you look at these cases, this is an adult and a child, and you look at the nose, we see that this person can't breathe through their nose. The person on the left with that high vaulted palate, that person had an injury to the nose at a really young age and just stopped breathing through their nose. So one would argue that once we damage the nose, that we affected the growth of the face. I want us to kind of get away from thinking about obstructive sleep apnea, because a lot of the treatment that says, oh, you know, dentists are too late, we don't have a big involvement, looks at obstructive sleep apnea. Well, obstructive sleep apnea, that's when you're pretty much already damaged. At this point, you're dealing with damage control. And pretty much the best treatment right now to treat obstructive sleep apnea is double jaw advancement. But that's not what I want us to focus on. I want us to focus on events before you get this severe. And this term is called obstructive sleep disordered breathing. So we're not thinking about OSA anymore. We're thinking about obstructive sleep disorder breathing. So what is obstructive sleep disorder breathing? Well, if you look at this, it's a spectrum. Basically, it starts with snoring, mouth breathing, and pauses in your breathing. Obstructive sleep disorder breathing does not have apneic events. Once you start having apneic events, you're into the apnea arena. We want to prevent the apneic events. We want to prevent the breakdown of the body. So I want you to start thinking about sleep disorder breathing more as a breathing problem. How you breathe during the day affects how you sleep and vice versa. And an interesting thing to note with the literature is that the severity of the symptoms is not dependent on the apneic events. So you could not have one apneic event, but you can be highly symptomatic. Children is a completely different beast. So if you want to look at this graph, if you look at the lymphoid organs, you're going to see that graph, that spikes in the first 10 years of life. That's the adenoid tissues and the lymphoid tissues. What also spikes in the first 10 years of life? Brain development. So in the first 10 years of life, you have the lymphoid tissues robbing the brain of oxygen. What does that do? Well, we know that if you don't get enough sleep, you're going to have mood swings, anxiety, depression. And we have studies to show that when we took out the tonsils, the adenoids, the symptoms, actually the mood swings, depression, and anxiety actually got better. We have studies to show that in the first 8 years of life, children with a lot of sleep fragmentation have special needs risk in education. So basically, there are 40 to 60% increased risk of having special needs education. We do have brain scans today that actually show changes in the gray matter with sleep fragmentation. And the disorder that's getting a lot of recognition right now, and many sleep physicians believe that this is a symptom of fragmented sleep, is ADHD. And it kind of makes sense if you really think about this graph. What is robbing the brain of oxygen? Now let's talk about growth and development. So this is even before the monkey study. Engel looked at class 2 and class 3 malocclusions, and he was saying, wow, I'm seeing that these class 2 malocclusions, they're like mouth breathers and they can't breathe through their nose. And these class 3s have large tonsils. So what I'm seeing is these large tonsils are making the mandible drop down and go forward. So this is before the monkey study. So this is his observation. McNamara did a cephalometric evaluation in 1984, and he was like, well, let's take a look at cephs. What are we seeing? And what we're seeing is when the adenoids are large, the maxilla doesn't stop. You see the maxilla stop, and then you see a clockwise rotation of the mandible. So this is the classic adenoid face, where you see that long face and that counterclockwise and clockwise rotation of the mandible, and you see that high angle of the mandible. And he confirmed what Engel was seeing. When the tonsils are large, the jaw drops down and it goes forward. So there's your class 3 relationship. When Guilleminault looked at all these different skeletal growths, he was saying, look, you know, these kids that are not obese, they have facial high risk factors. And what we're seeing is these high angle cases, these open mouth postures. So they argued and say pediatric obstructive sleep apnea in non-obese children is actually a disorder of facial growth. But what I'm going to say is the facial growth is secondary to the neurocognitive. So let's look at this girl. She's 9 years old. This is her anatomy. The orthodontist said she's 9, you know, before that, I'm going to get the best growth of the mandible right around the growth spurt. I'm not going to get that much before it. So let's just wait for more teeth to come in and then I'll address it then. And that's kind of accurate because the literature shows that the best time to address class 2 malocclusion is right around the growth spurt. But let's talk about the neurocognitive. 2 years ago, she was diagnosed with ADHD. 2 years ago, she was put on clonidine, Focalin, and Zyrtec, and melatonin. So she needs all that stuff to sleep and function. The father reports that at 2 a.m. she stays up, and she pretty much stays up until school starts, and she does this about twice a week. So the neurocognitive has set in when she was 7, but we did nothing because dentally she didn't need anything. But I'm going to ask you is, could this be an airway case? So what we did was we asked the right questions. We started with some sleep questionnaires, and she snores, heavy breathes, breathe through her mouth. We did a CBCT, and look at those adenoids. This girl cannot breathe, but people don't complain when they can't breathe. It doesn't hurt. They just drop their jaws and open their mouths. So what happened in this case is at 7 or even younger, when she couldn't breathe, she never complained about it. When the neurocognitive came in, we gave her medication because she wasn't complaining about it. But you can start to see the dental changes happen, but we're not going to do anything because we can address it later. But what if we address it? So this is an HRPO. This is a high resolution pulse ox. And what it does is it measures how many times you stop breathing at night. So this child had about 32 events where she stopped breathing for more than 10 seconds an hour. This 9-year-old child is as severe as a 70-year-old man, 200-pound man. So what we did with her was we went ahead and just did expansion. Just expansion. We did not take her adenoids out yet. Just by expanding her, opening up her nose, opening up the passages, we got her events down to half. So I'm going to argue and say that we really should look at these signs and symptoms. Yes, we can address the teeth later, but we just missed all the neurocognitive damage because now I have a hard battle to get her off these medications at the age of 9. So she's been medicated since 2. So the team approach to children really, I think, our restorative dentists and our pediatricians, you guys are the gatekeepers. You guys are the ones to open the door to invite everybody into the house. Basically, you're going to recognize the signs and symptoms. We're going to obviously make the appropriate referrals to the ENT or the oral surgeons to evaluate all the soft tissue obstruction. And from there, you're going to gather your team and do whatever you can to develop that face forward, because we are the best people to develop this face forward. And once we develop the face forward, we're going to need our myofunctional therapists involved to help the child breathe again. Because like I said, breathing doesn't hurt. When you can't breathe, you just open your mouth. So a child's not going to complain if they can't breathe. Eckert did this study, and basically in this study, they're looking at phenotyping different symptoms of OSA and seeing if we can target treatment based on where the obstruction is. And he said, there's no doubt this is an impairment in the anatomy. So let's look at this model again. And I'm going to ask you to change this model. And I think the dental team needs to get involved, and we need to get involved really early. And again, it starts with some screening forms, screening tools. And I'm a huge advocate that we have to co-diagnose and co-manage this disease. And I know a lot of people are like, oh, we can't diagnose obstructive sleep apnea. And that's not what I'm saying. We need to diagnose the craniofacial risk factors that are contributing to the patient having obstructive sleep disorder breathing. We are the best people to diagnose the craniofacial risk factors. Because as I showed you in the 2 cases in the beginning, nobody diagnosed the skeletal anatomy. These forms are available for you in asappathways.com. It's a pediatric form, but it can actually be used for adults in the data collection form. So, it's whatever form that you use. There's another form that we have. It's a nasal obstruction questionnaire. That's really looking for the nose. If you're going into adults, you either want to have some kind of validated questionnaire for adults. I'm not a huge fan of the stop bang, but it's validated. There's the Epworth sleepiness scale. But what you're really looking for is is there good nasal breathing? Are they a mouth breather? Are there any checks to show that there is any issues with growth and development? Now with children, it's not always about weight. You have the skinny kids that are also having obstructive events. So you want to check to see, is this child growing at a regular rate? For children and adults, you want to see how they're functioning during the day. Are they taking a lot of naps? Are they tired all the time? So again, you want to look at signs and symptoms of sleep disorder breathing, and you definitely want to hone in on the neurocognitive. You're going to get the neurocognitive before you see the dental malocclusion. Our model is to get away from damage control and to go into understanding the craniofacial risks and possibly preventing this disease. Obviously, we're dealing with growth and development, so you have to follow these kids for a very long time. Obviously, we're not going to remove all the stimulants in the child's life, but we can give the child the best anatomy so that they are ready for anything that any infections or inflammations that they have going along. We're not going to change the way we do the exam. We're going to do the same thing. We're going to look at the face. We're going to look at the maxillomandibular relationship. We're going to look at, is it a deep class 2, class 3? How soon do we want to get involved? We're going to look at the teeth. We're going to look at, is there crowding in the primary teeth? Do we see a lot of grinding, bruxism, gummy smiles? How narrow is that palate? We're going to really hone in on the tongue. Because remember that I said that the second most common site of obstruction is the tongue. And remember that when they took the soft palate out, nobody looked at the tongue because the tongue was still obstructive. So we want to look at, do we see any scalloping on the tongue? Does the tongue fit? Can the tongue move? Is it tethered to the tissue? And we have to look at the back of the throat. Again, the number one site of obstruction is the soft palate. So we want to look at that Mellon-Potty score. Is that soft palate obstructive? And what can we do about it? So this study was really nice because as they were phenotyping different signs and symptoms, they said, look, this is a largely dependent anatomical problem. So let's kind of review this airway a little bit. You've got your nasal pharynx. You got your velopharynx, which is right around your soft palate. And then you got the oral pharynx and the hypopharynx. So that's pretty much where like the tongue lives. If it's in the nose and the soft palate, these are who you're going to need on board. You're going to need your ENTs to clean up the nose, clean up the turbinates, possibly take out the adenoids, take out the tonsils. You're going to need your orthodontist, and you're going to need your orthodontist early. You're going to look at, where is that maxilla? We know that maxilla, that growth slows down after 7. So if we find a problem early, if you get that neurocognitive, if you have a question early, you get your orthodontist involved early. Because remember Riley, and we didn't get involved till she was 2 years on a CPAP, where she could have been on the CPAP. She could have had an orthodontic consult before they put her on a CPAP. You're going to need your oral surgeons involved for the late adolescents and your adults, because the best people to move the jaws forwards are your oral surgeons. The oral pharynx is where most restorative dentists live, because this is where we're thinking about housing, what houses the tongue. So when I see a lot of cases where people are showing teeth, my biggest question is, what does the tongue look like? Is there room for the tongue? And this is where actually periodontists, we can lean on our periodontists, because when we need to open up this bony housing, we need to open up space for the tongue. We don't want to push teeth out of the bony housing. So, and that's a big problem that we're seeing now with this airway movement, is we're taking teeth as wide as we can, but not respecting the bony housing. And this is where it's important for us to grab our periodontists. I put a sleep dentist in there because if the patient doesn't want to do any corrective procedures, then an oral appliance does really well. But an oral appliance only addresses the lower airway. So this area, what we're really honing in on, does the tongue fit, and where is the mandible? So 3 things I want you guys to really hone in on. And if you're not looking at the start, does the tongue fit? What does that throat look like? Can I see the back of the throat? What does that soft palate look like? I'm doing a lot of trials right now with the Fontana laser, where we're tightening up the soft palate. It's pretty neat. So the more studies I start doing, the more cases I have, I'll have more to share with you how successful that procedure is. And obviously we got to look at the nose, because once that nose is obstructed, it's going to affect skeletal growth. So let's look at this medical model. This is Jenny. She walks into the office. She's on a CPAP. She can't wear the CPAP. She doesn't care. She's 37 years old, but she's thinking like, you know, I don't have all the comorbidities yet, so I'm not worried about it. Can you just fix my crossbite? So if we go with a dental medical model, we're going to say, okay, why don't you like your CPAP? And if I'm going to fix this crossbite, I'm going to jump into the maxilla. So there's many ways for me to fix this crossbite. But since you have an airway problem, let me dive into the nose. So the nasopharynx, what are we seeing? We're seeing she's got a deviated septum. She's got a slightly retrognathic maxilla, high vaulted maxilla. We're going to look at the oral pharynx. We're going to say that she has a long, soft palate, and she's got a limited oral volume space, limited function. So if we go with our dental hat, we're going to say, okay, so you're on a CPAP, you can't breathe through your nose, you want to fix your crossbite, but you know what? I'm not going to fix your crossbite with dental expansion. I am going to attack the nose. I want to open up the nose because I can fix the crossbite, but I want to engage the nose. And that is exactly what we did. We opened her up, we engaged the nose, fixed the crossbite, and we had a side benefit that we got her breathing better. So I'm going to end it with, and I think it's amazing that you have an entire team here, is that we don't want to we can fix him at 64. It's just so much harder. There's so many risks at 64, but you know, at 64, the medical community has done everything that they can, but unfortunately they just did the wrong diagnosis. This guy had a skeletal problem at 37, but they addressed everything in the back. We want to start looking at our kids, because right around the late adolescence, they stop growing. So this is a key time for us to really talk to our oral surgeons, be like, hey, where are we in growth and development? Talk to the orthodontist. Can I manage this patient till he's old enough for surgery? And he may not need surgery, but can we manage him better? We can definitely manage this 9-year-old. We can definitely intervene this early, but I'm going to challenge you to intervene before you see the malocclusion, because the neurocognitive is already set in. So again, back to my mentors at the center, we're really big on risk assessments, and there are absolutely no absolutes. But when I look at these cases, I look at what is the risk of this child developing obstructive sleep apnea? What can I do? And obviously with Jeff, he always says, Tracey, could it be an airway problem? What can we do? This is a great quote by Theodore Roosevelt. It's in the moment of the decision, the best thing you can do in the right decision. The next thing is the worst decision, is a wrong decision. The worst thing you can do is nothing. And I urge you, when you think about my first 2 cases, the worst thing that happened was we weren't involved. We did nothing. Now we can still get in. It's just so much harder. That's what I got for you, Claire. So I'm going to stop share, and I'm just